Hello, and welcome to the Infectious Disease Podcast from Clinical Care Options. I'm your host, Jennifer Blanchette. Today's episode is the first in a short series titled Steps to the Future, Present and Future of PrEP, featuring expert insights on recent and ongoing advances in HIV pre-exposure prophylaxis. During this episode, Dr. Darrell H from Toronto, Canada, discusses approved and guideline-recommended oral HIV PrEP regimens and provides key insights on determining PrEP candidacy, as well as important considerations for specific populations or clinical scenarios, including adolescents, pregnancy and breastfeeding, and transgender individuals. For more information about Dr. Tan and for a link to additional educational content from this program, including downloadable slides, please visit the show notes for this episode. Now let's get started and hear what Dr. Tan has to say about optimizing use of oral HIV PrEP.
Hello, everybody, and thanks so much for joining us for this learning exercise on optimizing use of oral HIV PrEP. My name is Dr. Darrell H. I'm an associate professor and clinician-scientist in Toronto, Canada, in the Division of Infectious Diseases at the University of Toronto and at St. Michael's Hospital. So what we'd like to start off with is just talking about how to select the most appropriate candidates for PrEP. So who are the people that are most likely to be able to benefit from this exciting HIV prevention option? And we divided it up according to the main potential modes of acquisition for HIV. So you can see that for gay, bisexual, and other men who have sex with men, or MSM on the left, as well as for heterosexual women and men, PrEP is something to consider if people have been sexually active, but are not in a monogamous or closed relationship with somebody who has been recently tested and confirmed to be HIV negative. On the left, you can see that for MSM, it's recommended that PrEP be really seriously considered for folks who are having anal sex without a condom in the last few months or are anticipating that in the future, or who have had certain bacterial sexually transmitted infections, syphilis, gonorrhea, and chlamydia. Really, the risk is greatest specifically with infectious syphilis and with rectal gonorrhea or chlamydia, but all of those would be potential indications. And you can see that similar criteria exist, as you can see in the middle, for heterosexual women and men. Again, looking for infrequent condom use with more than one partner who might be at increased epidemiologic risk for HIV or who are of unknown HIV status. In some cases, it may be in the setting of someone who's known to be HIV positive with unsuppressed viremia. And again, we're looking at those specific bacterial STIs that we know can increase the risk for HIV acquisition. In the setting of injection drug use, we're really looking at individuals who have a history of sharing their works or sharing injection equipment. We also need to recognize that individuals may also be at risk for sexually acquired HIV in this setting as well. And across all of these categories, we're interested in individuals who are adults or adolescents weighing over 35 kilograms and who clearly do not have established HIV infection or acute HIV infection. This is an HIV prevention option for individuals who are known to be negative. Now, in upcoming 2021 CDC guidelines, there are going to be some small revisions here to really broaden the indications somewhat and really emphasize that we want to inform all sexually active adults and adolescents about PrEP, as well as people who inject drugs, so that people really know that this is something that they could benefit from, regardless of their specific types of sexual activity. So once you've identified that someone could benefit from PrEP, how do we go about actually selecting a specific regimen? Well, for all adults and adolescents at risk for HIV through sex or through injection drug use, a standard traditional option would be the use of daily oral emtricitabine or FTC with tenofovir disoproxil fumarate or TDF, so FTC TDF. And that's really based on a wealth of clinical trial data as shown in this next slide. There's a table here that summarizes some of the pivotal clinical trials looking at these nucleoside reverse transcriptase inhibitors, TDF plus or minus FTC, and really demonstrating that by blocking the activity of HIV reverse transcriptase, they are associated with highly statistically significantly reduced risks of acquiring HIV. And that's true for all of these different populations. The evidence base was really built upon in a number of additional open label or extension and demonstration project studies, particularly in gay, bi, and other men who have sex with men. You can see them listed here. Again, really demonstrating that in something closer to a real-world setting, you continue to see very high levels of effectiveness for these regimens. Now, some folks, when they look at these numbers, they may say, okay, that's very statistically significant, but the magnitude of decrease maybe isn't as high as I thought it was, or it's a little bit lower than I might have hoped for. You can see the numbers going from 44 up to about 75 or so % in the column on the right here. And it's really important to understand that the reason that those numbers kind of don't look as impressive as we typically think about or speak about when we're thinking about PrEP and its excellent efficacy is that we know that the degree of adherence with study drug in some of these pivotal clinical trials was actually pretty suboptimal. And it really comes down to an issue of adherence. Some of the studies went on to look at the level of detectable drug in the study populations and showed that the rare situations where someone did acquire HIV was typically in the setting of low drug levels. And if you redid the analysis in the setting of folks who did have high drug levels, then the efficacy estimates go up. And that's really summarized nicely in this summary plot showing a very clear linear relationship across trials, demonstrating that the more a study population or an individual adheres with PrEP, as with any medication, it's going to have higher effectiveness. But there are other regimens that can also be used for PrEP that we should look at. And specifically in the setting of gay, bi, and other men who have sex with men, there is also the option of looking at what's called an on-demand FTC-TDF dosing option. And although this is not formally recommended at this time by the FDA, it's off-label in that setting, other guidelines, including those from the WHO, the IAS-USA, and Canadian guidelines here in Canada where I work, do include the option of on-demand, also called event-driven and sometimes called 2-1-1 dosing that we'll talk about next. So this regimen is really based on a pivotal trial that was run by the French INFS called IPREGAY. It took place in France and at some centers here in Canada where I work, specifically in men who have sex with men who were at high risk for HIV infection. Now, transgender women were eligible to join the trial, but ultimately there were so few in that trial that essentially it was a trial looking at this population of MSM. And in the beige colored box on the upper right of this slide, you can see the way that it was recommended that participants take this on-demand regimen. Specifically, the idea was that if someone anticipated that they were going to have sex in the near future, then they would take a loading dose, 2 pills, about 2 to 24 hours before sex. So it does require that people can anticipate when they might have an exposure, followed by another tablet the day after, and then ultimately another tablet the day after that. And so that's the reason we also call this 2-1-1 dosing. I like to use that terminology because it helps patients remember this regimen that might otherwise be ever so slightly trickier to remember. In a situation where the person then went on to have another exposure in the next couple of days, then they essentially keep on taking those daily doses until 2 days have elapsed since the last time they were exposed. So it could become 2-1-1-1-1 dosing in certain cases. And you can see that both in the placebo-controlled randomized phase of the trial in the bottom left, as well as in the open label extension of this trial, the risk reduction associated with this regimen was really excellent, 86 or 97% risk reduction compared to the placebo arm in the randomized phase of the trial. And again, the rare cases in which people did acquire HIV, unfortunately, was really in the setting of suboptimal adherence. And although this regimen isn't super commonly used, I would say, at this time in North America, it is kind of gaining traction. Certainly in the setting of COVID, it's becoming more relevant for many people. And I should say that in the European setting, it is somewhat more popular. And we've seen in some pivotal studies, such as the PrEP study in the Netherlands, that when folks are actually offered on equal footing, both the daily and the on-demand options, there's actually a fair number of people who will choose either of them. And many people do choose to switch between these two options over time, depending on their changing circumstances. And it really emphasizes to me the importance of really laying all the options on the table for folks, not making assumptions about what's going to work or be easier or harder for an individual patient, use, really allowing patients to choose for themselves and empowering people with all the different options that do exist. Before leaving this topic, I do want to emphasize that on-demand FTC TDF PrEP should not be used for heterosexual individuals or really trans men and women because of the lack of data at this time. It's also not recommended for folks with hepatitis B infection because TDF FTC effectively also operates as hepatitis B treatment, and we don't want to be having people toggle on and off of that because of the significant risk of that leading to a hepatitis B flare. Now, next we'll talk about a third regimen that can also be considered for use as oral PrEP, and that's oral FTC TAF, or tenofovir alafenamide, as a daily regimen, specifically in, again, MSM or transgender women. Really, it's recommended by the FDA for adults and adolescents who are at risk for HIV through sex, but not including individuals whose sexual risk would be through receptive vaginal sex. There are ongoing trials to look at that setting, but it's not recommended at this time. So the whole reason that TAF, or tenofovir alafenamide with FTC, is even thought to be a useful option for use as PrEP and in treatment, of course, is based on this schematic that we're looking at now. It's important to understand that both TDF and TAF are actually prodrugs of tenofovir, and they're prodrugs of the form that actively works against the virus, the tenofovir diphosphate. And really, when we take these pills, the goal is to achieve high levels of that tenofovir diphosphate right in the lymphocytes. What happens with TDF when we take it is that it does quickly become metabolized to tenofovir even in the plasma compartment. And in contrast, TAF is able to be transported right into the cells before that metabolism really takes hold to any significant degree. And as a result of that, there's less of the circulating tenofovir in the plasma in the setting of TAF dosing, and therefore less that can move around to other parts of the body where it could be responsible for toxicities in the kidneys and the bones, etc. This pharmacologic feature also allows us to really get away with a significantly lower dosing of the product, 25 milligrams as opposed to 300, and that really leads to a smaller pill size, which our patients really appreciate as well. So based on this theory, this product, FTC TAF, was actually studied formally in a well-conducted large randomized control trial called Discover in cisgender MSM as well as transgender women, and demonstrated pretty clearly to be non-inferior to the standard FTC TDF for HIV prevention when used as daily PrEP. And that's shown in the images here. You can take a look that it was clearly favoring the FTC TAF compared to FTC TDF, although that difference didn't really reach statistical significance. So giving us confidence that this is an option that can be reliably used in this setting. And indeed, when we think about the safety of this regimen, both of them were well tolerated. Discontinuations were very rare in both arms related to AEs, but as would have been predicted based on the theory that we talked about earlier from a pharmacologic perspective, there were better bone and renal safety outcomes with the TAF compared to the TDF arms that were statistically significant. And you can see that based on the number of different tubular proteins or tubular markers, as well as the creatinine markers, as well as the bone mineral densitometry that was done at the hip and the bottom. Really, the only parameter that might have favored the FTC TDF that we need to be cognizant of is with relation to weight changes. And that's summarized in the table here on the right. There were modest differences that did reach statistical significance by week 96 between the two arms, a little bit less weight gain in the FTC TDF arm, but the magnitude of this is, I would say, fairly modest, about 1.2 kilogram difference after 2 years, so 2 to 3 pounds, something to keep aware of and maybe speak to patients about, but typically I have found that it's not a major factor that results in this being a deal breaker for many patients at all. So just to summarize the 3 different regimens that we've now spoken about, daily FTC TDF is really approved, as you can see in the traffic light color coding here, for really all populations that might find themselves at increased risk of HIV. The on-demand or 211 FTC TDF regimen is off-label, but it is guideline recommended for consideration in MSM. And you can see that the daily FTC-TAF, which we spoke about last, is approved for MSM, transgender women, and by extrapolation, it should also be appropriate for use in heterosexual men as well, although some of the guidelines haven't quite yet caught up and incorporated that evidence formally into their text. So with that in mind, how do we actually go about doing this? What's our clinical approach to initiating a patient on PrEP once we've decided that they're appropriate for it and we've thought about the different regimens? Well, one thing that is true across the board is that it is really, really vital to document HIV negative status using an antibody test in patients before they start PrEP, and this should be done as close as possible, typically within about a week of actually starting the medication. But recognize, of course, that even our fourth generation antigen antibody tests, they're highly sensitive, but they're not perfect, right? There's always still going to be that window period. And for that reason, it's also recommended that we screen people very carefully clinically to evaluate them for signs and symptoms of acute HIV seroconversion in the preceding few weeks or month. If there is any concern, it would be advised to be cautious, repeat the serology test and really be certain that the person is HIV negative, because if someone is using this medication in the context of being HIV positive without fully realizing it, of course, that's a recipe for potential development of drug resistance, which is a major concern. Of course, we should also think about contraindications, and unfortunately, there really aren't very many, right? It's really an issue of renal function requirements. You can see the creatinine clearance cutoffs that are recommended for TDF and TAF formulations respectively, greater than 60 or greater than 30 mils per minute, lower threshold in the setting of dialysis. We've spoken a little bit about hepatitis B, making sure that you know the person's hepatitis B status. Don't use the on-demand in an MSM who is HBV positive. And if someone is negative for this, use it as an opportunity, use PrEP overall as an opportunity to really engage a person in comprehensive sexual health care. So vaccinate them against hepatitis B, but also against other vaccine-preventable infections, hepatitis A, human papillomavirus, test, screen for hepatitis C, for other bacterial STIs, and really link patients to appropriate care for those conditions as they're picked up. Next, we'd like to move on and just review the approach to monitoring patients once they are initiated onto PrEP, and that's summarized in this table here. You can see that at PrEP initiation, it's recommended to do a thorough assessment, including HIV, STIs, hepatitis serologies, but also think about pregnancy in those who have the capacity to become pregnant, look at renal function, assess people's risks and indications, and really counsel people carefully about the importance of adherence to this regimen, and as well integrate discussion around other strategies for risk reduction related to HIV and other STDs. And then we typically engage with our patients every 3 months or so after that. At minimum, the requirement is to repeat the HIV assessment with a test and a clinical assessment, as well as to do an STI assessment and pregnancy testing as appropriate, engage those people in adherence counseling and behavioral risk reduction. And then the frequency with which you actually do STI testing varies somewhat in different guidelines. In the CDC guidelines, it's recommended at least every 6 months, but there are data to say that it should be even more frequently in the setting of individuals who truly are more sexually active. So let's next talk about how we approach that counseling piece. We've kind of glossed over it so far. There are some details that are important to mention to people as they're starting and stopping PrEP. Based on some of the pharmacologic data that we have. And really the issue is, how long does it take before someone can consider themselves protected? How long does it take, as our patients say, for the PrEP to really kick in? And based on the best pharmacologic data, we recommend that people, stick with daily dosing for about a week or so. That might be a little bit overly conservative. We don't know exactly what the optimal PK cutoff is or correlative protection, but this is a reasonable recommendation that is widely made. We don't quite have enough data for FTC-TAF yet. It may be better than that, but that's typically what we recommend. And if someone's going to stop, remember that the protection, quickly wanes within about a week or a little more than that after discontinuations. Different guidelines will have slightly different comments on exactly how to counsel people around the stopping. Remember that when you're stopping, you should also be cognizant of the person's hepatitis B status. If they're positive at baseline, there's a risk of flaring. That's uncommon, but just watch for that if you do have a hepatitis B positive individual, and then talk about alternative prevention strategies, including PrEP access as well if someone's choosing to stop their PrEP. In the middle, of course, we do want to emphasize again the importance of daily adherence or regular adherence if someone's taking the on-demand regimen. That's really critical to efficacy, as we've talked about earlier. And there's a lot of different tools that I'm sure clinicians are quite familiar with in their experience counseling about adherence to medications in general that are really useful to speak about explicitly with our patients. Remember that many of these individuals might be coming to you in the setting of really not having a lot of other health issues in the past because they're seeking out a preventative option. Some other implementation considerations that we really wanted to emphasize are listed here. Really remember that PrEP is this amazing potential gateway to comprehensive sexual health care, as we've spoken about before. Think about those other vaccines. Make sure you've engaged your patients in prevention of other things besides just HIV. Think about their mental and behavioral risk factors and consider how their mental health might be tied to their STD/VI risk, and consider linking them to other services for that, for family planning services as well. Now, an elephant in the room when we speak about PrEP is the cost of the medication, potentially depending on your healthcare setting, the cost of healthcare services in general. This is widely variable in different geographic settings and jurisdictions, so we won't speak about it in detail at this time, but it is important for anyone who's going to be thinking about potentially getting involved in PrEP delivery, which is so important, to really know what the cost options are, the coverage options are in your setting. Advocate for them to be broadened, because this is really a powerful intervention that we want to have more and more people benefit from in the future. Now, just to wrap things up, we're going to comment on a couple of special populations that we want to pay attention to. How does PrEP differ in the setting of adolescents or pregnancy, transgender individuals? Really, at this time, there are limited information on the potential for long-term toxicities, specifically bone and renal, with the TDF-FDC option of PrEP in adolescents. But this is something we want to be cognizant of, because, of course, adolescents, for example, are still developing, they're still building their bone mass. At the same time, this is a population, a setting in which adherence can often be a major challenge, both with medication and even just engagement in care. There are special disclosure issues that need to be thoughtful about that our adolescent medicine providers are, of course, expert in. But remember also that young individuals clearly have the most to gain from not acquiring HIV in terms of just their age and the long number of years of life ahead of them. So it's not a population that we should at all be ignoring. It's really important that we really focus and develop more data and experience with the use of PrEP in this important population, which does have rising rates of HIV acquisition. In terms of pregnancy, this is a setting where patients do often ask a lot of questions of us, that we know, of course, that pregnancy itself is associated with an increased risk of HIV acquisition itself. Now, unfortunately, there are still just a modest amount of data on the safety and efficacy of PrEP in the context of pregnancy or breastfeeding. But we can extrapolate to a decent extent from the extensive experience with the use of FDC-TDF in HIV positive individuals, including pregnant women. We know that there's really no evidence from the antiretroviral pregnancy registry suggesting any link between FDC-TDF and teratogenicity, so that gives us more comfort with its use. It's important, of course, that providers discuss the potential risks and benefits of PrEP use in pregnancy in order to enable women to make an informed decision for themselves and really individualize that decision because of the uniqueness of that setting and the importance of preventing HIV in that setting as well. Finally, we have spoken somewhat already about indications for PrEP and regimens for PrEP that would be appropriate for use in transgender persons. Remember that the burden of HIV is disproportionately higher here, and that's an unjust reflection of a lot of discrimination in our society. So we really need to be attentive to that as clinicians and try to counteract those forces. We know that PrEP is effective in transgender women with good adherence as based on prior clinical trials, and we need to incorporate a careful clinical history taking into our PrEP assessments, including types of sex, use of gender-affirming hormones, gender-affirming surgeries, potentially use PrEP as an option, again, to link people into more appropriate forms of care if that's what they're seeking. There are some comments here as well at the bottom regarding just considerations about the ways in which gender-affirming hormones can be relevant to consider. Remember that testosterone use can elevate serum creatinine. So in the setting of trans men, think about how you're calculating someone's creatinine clearance. Use male equations in the setting of testosterone use. In the setting of transgender women who are using feminizing hormones, it is really important to note that there have been careful studies showing that plasma tenofovir concentrations are modestly lower, 13% lower, versus PrEP without the use of hormones. Now, the clinical relevance of this does remain a little uncertain, I would say, and in general, we think that the levels do still remain in the range that would confer protection. But it does give us a little bit of pause, and important to name that fact, because this is an important question that many of our trans patients ask us, and unfortunately there are data that have been coming out looking at this exact issue. The converse is not true. So reassuringly, we can tell our patients that PrEP co-administration does not seem to affect levels of feminizing hormones. So we'll wrap up with just some key take-home points. I think we've been emphasizing throughout this presentation that PrEP is really effective, it's really safe, it's an excellent HIV prevention option that really clinicians have a key role to play in expanding access to this and uptake of it. At this time, daily oral FDC-TDF is the only FDA-approved medication for folks who would be at risk of HIV from receptive vaginal sex or people who inject drugs. Fortunately for gay, bisexual, and other men who have sex with men, there's really a wider menu of options. The on-demand 211 FDC-TDF dosing would be an option, as well as the daily oral FDC-TAF option that we spoke about earlier too. And really, as we continue to expand the number and variety of PrEP regimens available to different groups of people, it's really hoped that we'll be able to appeal to diverse populations, really let people know about the diversity of options available to them so that they can make the best choice for their own health. And finally, just to reemphasize that PrEP is just an amazing opportunity, not only to prevent HIV, which is so important, but to really engage people in comprehensive care, including but not limited to their sexual health, their mental health, and other aspects of their well-being. So thanks so much for your attention. It's been a pleasure to chat with you today.
Thank you very much for sharing those insights, Dr. Tan. And thanks to our listeners for joining in. As a reminder, to view the full educational program, Steps to the Future, Present and Future of PrEP, on the CCL website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.